I am the head of the first department of obstetrics and gynecology on the Medical University of Lodz in Poland. And coming to straight to my presentation, the biochemistry screening is containing two tests in chronological order. The first was the second trimester biochemistry screening with a triple test, then enriched in inhibin and then called quadruple test. And now we've got for many years the basic test in our prenatal screening, which is a first trimester combined screening. With the parts is ultrasound scan with nuclear translucency as a main marker, what we know from the lessons which we get in fetal medicine foundation. And of course, there is a part of biochemistry with free beta HCG and PAP-A concentration assessment. So this is the first step of the screening, the ultrasound scan with this assessment of many ultrasound markers of fetal aneuploidies, and then we take some blood sample and may measure the biochemistry test, so-called double test with free beta and PAP-A, and then we have an excellent combined screening with a sensitivity of 90% for 5% false positive rate. This is the basis. I have to say some words, of course, also about second trimester, the triple test, AFP, beta HCG, and estriol, a low characteristic test for now. Then even with inhibin A, there is still 81% sensitivity. And what is more important, this can be made later in pregnancy. So for now, this is a little bit outdated, and we don't recommend it for the current prenatal screening. And then we have the new generation of the screening. This is an assessment of fetal DNA in maternal circulation, so-called NIPT, non-invasive prenatal testing, with really brilliant characteristic of over 99% sensitivity, a high predictive value, and a very low false positive rate for Downs, but also for the other aneuploidies like Edwards, Patau, and there are, of course, not so good results for microdeletions of sex chromosome aberrations. So there is a question, should we replace biochemistry with NIPT? Then we have to take a closer look to the both tests. The first is the first trimester, of course, screening, the basic one. The advantages are screening for preeclampsia as an additional value. Then, of course, also screening for fetal growth restriction. And a big advantage, we have to say, is quite cheap. But the screening has also disadvantages as a higher rate of false positives, which may wake a lot of patient anxiety. Then the result of the high false positives is a high percentage of the invasive procedures. And of course, it has lower sensitivity than NIPT, than fetal DNA in maternal blood. But NIPT has good advantages as a higher detection, what was already told, for then first trimester combined screening, a high predictive value, and then we can start with the test from the 10 weeks of pregnancy, and then we have a peace of mind of the mother and father, so-called parents' reassurance. There's big advantages, but also there are, as in everything in life, disadvantages. False positive results for triploidy is not available for triploidy. False positive results for microdeletions, which cause a low predictive value for microdeletions testing, a low fetal fractions, which may cause a no-call, so-called no-call test, so no result at all. And for the country as Poland, where it is not reimbursed, a very big disadvantage, the high price for the test, much higher than for the first trimester screening. So we can weigh both disadvantages and advantages. And then we come to the topic of today's webinar, of today's meeting, the preeclampsia screening. The conclusion of the publications, which are on the right side of the slide, coming from the Fetal Medicine Foundation, is that the first trimester screening is the preferred biochemical marker, is of course the PLGF, the placental factor. But, however, if PAP-A is used rather than PLGF, and this is the case of Poland, the same detection rate can be achieved, but at a higher screen positive rate. So when we look at the table here, we can see that for the same detection rate of preeclampsia, we have a much higher false positive. So, but we even only with this combined test, where is a history, mean arterial pressure, uterine arteries, and PAP-A, we can also have a detection rate on the same level like PLGF, but we have more false positives. And furthermore, I have to say that the low PAP-A, as we know from evidence-based medicine, is connected with a poor pregnancy outcome. On the left side, we see the patients group with a normal PAP-A level, where the majority of the outcomes of the pregnancies was uneventful, and only the minority were complicated. And in contradiction, when we see on the right side, then we see that the outcome of patients with low PAP-A, only the minority was uneventful, and the majority suffers from many complications. So we can say that the low PAP-A is a danger in pregnancy, because this is a risk factor for intrauterine death, placental abruption, fetal growth restriction, hypoxia, and preeclampsia. Then in this, in the middle of this problem, we've got a national screening program, which started in 2005. So we've got already a big experience in screening, which is containing a first trimester combined screening, then second trimester scan, invasive testing. But as I already told you, NIPT is not reimbursed, which is a problem for the pregnant women, also for the doctors. The indications are quite wide. The main is age over 35 years old, but there are also many others which give us a possibility to include more women into the program. I will show you here that the live births in Poland is about 350,000 yearly. It's decreasing, but still is quite 400,000. And performing the program on the national scale, we may have about 1/3 of the women which are screened. It means it's over 100,000 women is screened. So it's a quite big group. So we feel that it's a good time to make a recommendations which may bring some order in prenatal diagnostics in Poland, and we do it together with the Polish Society of Human Genetics. As you see, this is quite new situation, submitted in 21 in December, now printed in Ginekologia Polska, our English written journal. So the main point is that the idea of the screening is quite taken from the Fetal Medicine Foundation. This is a kind of contingency screening, starting from first trimester. The low risk, we do nothing. The high risk, we do invasive. When intermediate, so the toughest group to decide, then we offer the NIPT. Furthermore, in the recommendations is told that the screening is non-invasive, that the screening should be carried by the qualified physicians with certificates of FMF and Polish Society, and that all markers should be assessed. And the recommended screening tests are the combined tests, but also NIPT for this intermediate risk group. The pregnant women should be counseled very carefully. informed about additional benefits too. It means that when we offer the double test, we don't think only about the screening of the aneuploidies, but also about preeclampsia, what is the a lot of which causes a lot of problems in the pregnancy, what was said already by our chairman. So the question is still, should we replace biochemistry with NIPT? I can draw some conclusions. With the first trimester's combined screening, we can perform effective screening for preeclampsia even without PLGF. Patients should be informed about benefits of risk assessment of preeclampsia and FGR, and these 2 points are very important in the country where the screening for preeclampsia is not reimbursed at all. So the assessment of PLGF is still expensive, and until it will be not reimbursed, the first two points describe how we can do it on the other way. And for the aneuploidies, so far, there is no proven cost effectiveness of NIPT use as a first-line screening method. We are on this, we state last the first time, maybe this first trimester screening, that is still valid, and then NIPT for the intermediates. Thank you for your attention.